Hello, I'm Dr. John Kruse, and hopefully I won't have more technical delays today. So this is a question and answer sessions, and the information here is for informational purposes only. It's not specific recommendations about treatment. You should consult with your treatment team. I'm open to questions about the videos released this week. I will review them in a moment, and I'm also open to other questions about ADHD or mental health more broadly. And I've included in the chat a link to a week from Friday. So Friday the 19th, I'll be talking on Medium Day. That's the forum where I write each week. And they're having their annual celebrations. There'll be a few hundred, maybe 100 speakers throughout the day. It's free. I'll be talking about writing for an ADHD world there. And Max has a more efficient link to that than the one I could find. So thanks. So the videos, and also a shout out to the subreddit, if that's a better forum for anyone for writing questions or connecting with the community about ADHD topics. So the two videos that came out this week, one was a new one called Myths About Stimulant Medication, and the other was about, is drug testing necessary for ADHD patients? And the myths talk, many of these I have separate individual videos on this channel about, and I'll just sort of run through, and as I run through, I'll provide the counter to the myth rather than the myth. So number one myth, or counter to the myth, is that our term stimulant is not a precisely defined, accurate, or particularly useful way of designating anything. Number two, Ritalin does not really act like a strong stimulant. Number three, stimulant medications will not rot your brain used in a therapeutic dose in a therapeutic way. Number four, non-stimulants definitely can work quickly. It's not just stimulants that do that. Number five, stimulants aren't a cure for ADHD. They can be tremendously helpful. They can be life-saving, but they're not going to ever eliminate all ADHD symptoms. Number 1, 2, 3, 4, 5, 6 now. Tolerance does not seem to happen for the majority of people on stimulant medications. So it is not universal. And seven is that there are many people who do well on a high dose of stimulant medication. And again, my shtick there is that the term high is meaningless. Rather than focusing on milligrams, we should focus on, is it having benefits? Is it causing side effects? And we know that some people will respond to doses much lower than the norm, and some will require much higher doses. So those are the myths. I'm happy to talk more about any of those. The second video was my stance that drug testing is not necessary or even appropriate for most people on ADHD, taking stimulants or not. So there are many clinics, centers who have a requirement for urinary drug screens for patients who are about to take or are on ongoing stimulant prescription. I have not found any evidence to suggest that that lowers the rate of substance abuse problems. I should say substance abuse problems are a potential part of the treatment with stimulant medications. They seem to be rare. They certainly can be highly problematic, dangerous, and even lethal. So I don't want to trivialize it. But again, the evidence that uniformly requiring urine tests is going to prevent this. It may prevent it from happening in your clinic, so the person may go elsewhere, but that's not, I would argue, an effective treatment regimen. And the very act of demanding or asking this is highly detrimental to the patient-doctor relationship. And the positive patient-doctor relationship is one of the best predictors of good outcomes for people. So that's those videos, and I see there's a whole bunch of questions already today, so I will launch into there. Hello, Jack. That's just a shout out, I guess. James Alexander, hello again. How quickly would you expect patients to notice the effects of selegiline on their ADHD? So selegiline is a monoamine oxidase inhibitor, so it's having some effect on boosting neurotransmitters within minutes to hours of taking them. And again, from this is oversimplifying, but making more dopamine and or norepinephrine available or extending the lifetime of their use at the receptor endings seems to be at least a major part of how stimulants work, which work quickly. So my expectation would be you should be seeing ADD benefits for selegiline very quickly within that day, certainly. Excuse me. So, hello, Dennis. Dennis asks, do cigars deliver nicotine to the bloodstream faster than cigarettes? So I don't know if there's actually research on this. There may well be. I can remember claims that the method of inhalation, that when people, and again, these are going to be group statistics because you can smoke a cigarette or a cigar any way you want to, but that there's more of a deep inhalation. So you may be getting a bigger hit from a cigar than just sort of absent-mindedly puffing on your cigarette. So to me, it's conceivable. It might be slightly, and I wouldn't say that it's faster. It's that you're getting a big concentration more quickly, but that it isn't overall faster. And again, with particularly with dopamine and norepinephrine systems, it may not just be the concentration of the neurotransmitter at that receptor. It may be how quickly that's changing as well. So yeah, to me, it's conceivable, but I don't know the actual science has been done. So Dennis's next question is, I spoke to a somnologist, sleep study expert regarding sleep fragmentation. He suggested trying mirtazapine. Can this drug enhance sleep continuity? So mirtazapine is a atypical antidepressant. It's sold by under the brand name Remeron in the United States. It's not an SSRI. It's not a simple anything. Its indirect effect seems to boost both serotonin and dopamine availability, and it has two really common side effects. It's sedating for most people, and not just sedating, but strengthening sleep. So, strengthening particularly deep, slow wave sleep. But there is evidence that it, one, decreases sleep latency, so helps you fall asleep more quickly, and increases sleep efficiency. So you are asleep for a greater percentage of the time you're trying to sleep. So that speaks to it should, on average, or it's reasonable to expect that it could help with sleep fragmentation. Yes. So Remeron's other common side effect, and it's only common, happens in about 20% of people, but about 80% of people are sure that it's going to affect them, is it can have pronounced effects on both, well, on appetite. So it does not seem to affect metabolism like the antipsychotics that cause rapid weight gain, but its effect on appetite for food can be so intense. I've actually had um, professionals who have good control over other parts of their lives literally have trying to put locks on their food cabinets so they weren't eating um, sort of in an absent-minded, lot aware way late in the evening. So James Alexander asks, wouldn't you expect patients to start experiencing new bad side effects from atomoxetine, like emotional numbness, after a month or two, since that's when the antidepressant effects should kick in, even in patients who don't have depression? So yes, it's conceivable. So atomoxetine Strattera, I'm not a big fan of. It clearly is helpful and wonderful for some people with ADHD. It clearly rigorously passed tests to get approved for that. But it has so many initial starting effect or starting side effects that most people can't tolerate it. or have to wait months before they can build up to an effective dose. But yes, I would think there would be one set of side effects that would be initial and related to the direct effects that this drug is having, and probably more gradual side effects that are only appearing after several weeks on it that are due to the indirect effects this drug is having. So, James Alexander has a question from last week. In talking with people with social anxiety and people with autism Asperger's, have you noticed behavioral differences between the two groups during your conversation? So, behaviorally, I'd say many of the times people with social anxiety, when they're talking about their social anxiety or talking about other things, are displaying signs of being anxious. Um, some of them can look like ADHD signs. It can be foot tapping. It can be body tension. It can be um, expressions or micro expressions of worry, fear on their faces. And this is, again, oversimplifying or dichotomizing people on the autism Asperger's spectrum, even if they're being socially a little weird or awkward, often are fairly placid and seemingly unaware of their, um, don't display as much discomfort. I'd say the other thing is eye contact. So if, and again, this is an oversimplification and I'm sort of dichotomizing, but someone with social anxiety, it will be an averted gaze. It will be specifically not maintaining eye contact. It will be looking away. Whereas the autism spectrum, it may be more a random, eyes are just everywhere in a non, I would, that's a loaded term, but nonsensical pattern. So it's not that they're specifically avoiding it. It's not that they're engaging in normal ways. And this is, I mean, movement abnormalities have been detected in the first year of life of kids who wind up being somewhere on the autism spectrum, which is part of, before they get lots of these vaccines that some falsely think are associated with developing autism. Again, this is part of the evidence that it's not vaccine driven, is that they are displaying some aberrancies before they get a host of vaccinations at between 1 and 2 years old. So those are, again, overgeneralizations. You can certainly have social anxiety and autism together. Um, but I do think body language and paying attention to what's concordant and discordant between the content of what someone's saying and how they are acting out on it are helpful cues in sorting out what's going on. So, hello, Max. What does it mean when you say ADHD is a wiring issue? And following up, how does science observe the link between the wiring issue and ADHD, and how do stimulants relate to that wiring issue? So, the comments in the context of um, sort of an older view that because all of our, not all, but most of our medications that help with ADHD, certainly all the older ones, boosted dopamine and or norepinephrine. And the claim was, that's going to fix ADHD. And it, again, never completely fixed it. So when I'm saying, so that would posit ADHD is primarily or fundamentally a neurochemical issue, and just applying or supplying or adjusting the levels to the right level will get you free of ADHD symptoms. And when I say it's a wiring issue, what I mean is that it is, from the evidence I see, ADHD is as much about the strength of connections between different parts of the brain. Um, so, how the brain is wired together. And clearly, dopamine networks, or networks that use dopamine, networks that use norepinephrine, are an important part of that wiring. but that just spritzing or lowering or regulating dopamine and norepinephrine isn't going to resolve it. It may help, again, strengthen some connections that are important and being underutilized in some situations. So I'm not sure. Somehow I jumped around. Oh. Yes, so I don't know if I'm not sure I answered the last part of that, and I'm seeing questions out of sequence, or I missed. So, so how do stimulants relate to a wiring issue? So again, a stimulant can activate a certain part of a wiring or circuit and either strengthen it right then as a direct effect, or hopefully over time strengthen connectivity and change patterns of connectivity after something that's understimulated is stimulated enough over time. So that's how I would say neurochemistry is interacting with neurocircuitry. So I guess I missed a question from Jack. Jack asked, why do autistic people struggle so much with sleep? What can be done to fix this sleep problem? So I don't know much of the research specifically on what specific sleep deficits or problems are connected with autism. What I can say is overall, I don't know of a single major mental health issue where, so whether you have depression, whether you have anxiety, whether you have bipolar disorder, whether you have schizophrenia, whether you have ADHD, all of those are connected or have a strong association with sleep problems. ADHD is one of the strongest connections there. With ADHD, we know there are specific genes that seem to be affected. That, for example, you're more likely to have genes for late phase sleep patterns, so that you're more likely to go to sleep more easily late at night and to wake up late in the morning rather than an early bird pattern. Um, so, whether there's a polygenic influence that tracks mental health issues with overall, I mean, if you have bad sleep, and so part of this is bidirectional. If you're sleeping poorly, we know that that exacerbates ADHD symptoms. We know it exacerbates depression. We know it can make mania worse if you're in mania. So again, so what can be done to fix the sleep problems? Again, the strongest approaches are good sleep hygiene approaches. So that's making sure you have a regular bedtime, that you're giving yourself an adequate amount. And for most people, it's close to 8 hours each night. And it needs, again, to be the same 8 hours, and either giving yourself less or allowing yourself substantially more. If you're allowing yourself to sleep in, if you go to bed at midnight, but you allow yourself to sleep in until noon each day, you are likely to increase the time you're awake and tossing and turning. So if you decrease that to a window of closer to 8 hours, you're likely eventually to wind up consolidating sleep in that realm. So making sure you're avoiding alcohol, stimulants, other drugs that can disrupt sleep. So um, making sure your bedroom is the right temperature, making sure you are, so the biggest source of insomnia sleep problems, something like 90%, are associated not with a defective or broken sleep system. Some people do have that, but far and away much more common is that you're not turning off your daytime arousal systems. So having regimens, habits, patterns, ways to unplug yourself from external stimuli, calm yourself down, get yourself into a parasympathetic nervous system state. All of those can be helpful. So Hello, top tier billionaire again. What do you think about the connection between mycotoxins from coffee and other sources and ADHD? Also, caffeine and ADHD make symptoms worse. Um, so, mycotoxins are toxins coming from molds and fungi that are contaminating coffee and other sources. Um, I know it's a field full of speculation and people offering theories and anecdotal evidence. So, person X had high levels of a certain mycotoxin titer and had certain problems. I don't know of systematic, rigorous research looking at a strong connection. Is it certainly possible? Yeah, I guess I can't say more. And also, what I don't know is how often, even if coffee beans are contaminated, isn't boiling coffee, I mean, likely to reduce the amount so I don't know how many mycotoxins are actually stable to being boiled or not. Certainly, that has some antifungal effect, but the mycotoxins are the toxins produced by the fungi, so you might even kill all the fungi, but still have toxins present. I just don't know the stability of different mycotoxins in boiling water. Um, I mean, caffeine itself, there are studies going back to the 1970s showing caffeine can effectively treat ADHD symptoms. And in some of those early studies, it looked as effective as methylphenidate, Ritalin. Um, so Cesar Masso asks, so methylphenidate is not as strong as Adderall. So two things in terms of as strong. So one on a milligram to milligram basis, it's not equivalent. So usually something closer to 10 milligrams of methylphenidate is more closely equivalent to 5 milligrams of Adderall. These are very rough approximations. Individual results will vary. But even if you get an effective dose, a relatively effective dose, a smaller proportion of people will respond to methylphenidate for their ADHD, and their symptoms will be improved to a smaller extent overall. Um, so, by that measure, it's not as strong. And particularly, one of the rare but really bad side effects of amphetamine products is amphetamine induced psychosis, maybe happening 1 out of 400, 500, 600 people, somewhere in that range. That seems to be substantially less common or maybe not even an issue with methylphenidate. So, yes, by those measures, methylphenidate is not as strong, even if used at an equivalent dose. So, glad I answered your question, Dennis. And if there's a follow up, Cesar, let me know. Sorry. So, hello, Nick Lewis. For my clinical practice, what agents would you say showed the best results for comorbid OCD and ADHD? Um, so standard OCD treatment is serotonin reuptake inhibitors and or clomipramine. So most of the tricyclic antidepressants were serotonin and or serotonin and norepinephrine reuptake inhibitors. Clomipramine, which was a nafranil, of all of those is the most strongly biased towards serotonin. So it may be a more potent serotonin reuptake inhibitor than drugs we consider SSRIs. That's the standard treatment for for OCD. So I have many people who have both ADD and OCD on a stimulant or on something that's promoting dopamine and norepinephrine for their ADHD and on a serotonin reuptake inhibitor. So clomipramine itself, though, even though it's a very potent SSRI, also has effects on the muscarinic system, has effects on the histamine system, it tends to have lots of side effects like sedation, constipation, orthostatic hypotension, um, that the tricyclics do. So I'm not a big fan of that. So usually, um, my combination with OCD and ADHD may be an SSRI and Vyvanse, and some people. So the unlike treating depression with SSRIs, where the majority in most studies of people respond, a sizable minority doesn't. With OCD, almost and respond means marked, if not complete, resolution of their depression. With OCD, what we're most often able to accomplish is a reduction in symptoms, but not an abolition of them. And very often, in addition to an SSRI, that needs to be supplemented, and often with a what started out being antipsychotic medications, and Abilify is the one I would use most often, probably overall, because it has relatively better side effect profile than some of the others. It's not perfect for everyone, but it seems that it also can be particularly helpful for ADHD. So I do have a video on antipsychotics where I focus on risperidol and Abilify, aripiprazole for ADHD. That might be relevant. I think I have a video on OCD as well. Um, so James Alexander has another question. Why do I take LumaTC brand lithium orotate, which has curcumin, MAC, and other ingredients instead of a supplement with just 5 milligrams of lithium orotate? Is it because you believe there's some benefit from the other ingredients? Yeah, this would be the simple answer. And probably when I started, and I think I had on the top of my 3, 4, 5 years ago, lithium orotate was just less readily available at that time. I think also I had read, and I'm blanking on his name again, which shows maybe it's not working as well as it could. Um, I'm not going to be able to recall his name. The person who had written the book, and someone came up with the book name, and it's on my bookshelf. Promoting Lithium, I think he specifically in his addendum or his website recommended this product. Part of it is that right now, the data on supplements is there's a lot of products, substances that have a little bit of data that are suggestive or encouraging or hopeful. And whether everyone's going to be a little helped by lithium, or whether there's population that's helped by lithium but isn't by curcumin, or is by curcumin and isn't by vitamin B12 or some others. So a scattershot approach of substances, none of which have been linked to high rates of problems, seemed appealing and reasonable to me, but not enough that I was recommending it to any of my patients. So I have a different threshold or criteria for myself in terms of the risks I was willing to take versus what I would make a general recommendation for more general recommendation. To me, I feel like I need more clear evidence of benefit. Um, So Jack asked, could autism and ADHD be considered two sides of the same coin, the executive dysfunction coin, more precisely, autism affecting more social executive functions and ADHD, the productive executive functions? So one is that there's a clear association between autism and ADHD. If you have one, you're more likely than the general population to have the other. Um, Two, many of our Mental health conditions seem to have some common polygenic influence. So many genes contributing each a tiny bit. And there's certainly considerable overlap between some of the genes contributing to autism and some of the genes contributing to ADHD. However, I think, and there are some researchers who believe that they are both, that they are same condition that's unfolding differently as people develop. Um, I think they unfold differently enough, and there's been particularly recent studies showing different areas of brain activation or inactivation or different circuitry issues that I think they are different enough that they should not be blurred. And I do see many clinicians, particularly clinicians with less medical knowledge or awareness, telling everyone who comes in the door with clear and robust ADHD symptoms that they're dealing with autism. So I think, at least in the San Francisco area, I think autism spectrum issues are being both widely overdiagnosed and confused with ADHD and things like social anxiety. So that's where what I would say for there. Um, but is there can we consider executive functions and be a common um, part of the disruption? Yes, I think that's a fair thing to say. So Cesar is asking about, do I have some tips on concentrating better for people with or without medical treatment with ADHD, and maybe a video? I don't think I have. Um, and the simplistic thing I would say is, wherever you are on the ADHD spectrum, including not on it, practicing will get you better. And it's hard to practice, which is boring and repetitive if you have ADHD. So there are tricks to practicing. Removing distractions are important. And that's about all I can say at a simplistic level. Transcription says I'm ADD, and sometimes I wonder if I'm on the spectrum. I find I contact extra noise. I can and do engage in it, but it's a lot of extra data to simultaneously process, makes a huge difference. Yeah, so that highlights one thing I didn't say when I was talking about autism and ADHD. You absolutely, well, I did, I guess. I mean, you can certainly have both together. It's good to say it explicitly. Um, I said they were over associated. Um, so Richard Nixon asks, does methylphenidate come positive in amphetamine tests? So there are a variety of tests out there, and the structure of methylphenidate is not that distant from amphetamine. So some tests that are looking for a stimulant would register positive for both. There can be gas chromatography and other tests that more clearly can differentiate amphetamine from Ritalin products. So, and again, part of my video on this talks about even drugs like Wellbutrin, which are much more distantly related structurally and don't, most people would not consider to be a strong stimulant, or a stimulant in the sense we're using it here for ADHD, can often produce false positive tests for amphetamine. So part of it depends on what tests are being employed. So Max asks, in severe ADHD patients who are barely functional and also suffer from comorbidities like OCD, addiction, depression, anxiety, where do you even start as a psychiatrist? It seems so intractable. So that's a great question. And part of it is each individual should be treated as an individual. So, but my global answer is that many times I see people or experts saying focus on the depression first because that's potentially short term. And while that's still there, it's harder to evaluate all the other things. It's, say addiction is high there. On the other hand, I think you can build a strong case for that ADHD, by definition, is present since early in childhood. It's pervasive. If you're not treating that or addressing that, fundamentally, you can't treat or address the others. So I'm jumping all around here. I'd say addiction is, I would probably start with here, because if you're having an addiction, that's potentially not just disrupting your ability to sort out whatever else is going on, but also interfering with getting better and has potential life ending possibilities connected with it. So I would probably put addiction and ADHD near the top of the list. Now, if someone's suicidally depressed or so depressed they're not getting out of bed, then I would treat that actively as well. Part of it is why duloxetine Cymbalta has been one of my favorite drugs over the years, because duloxetine at least has the potential for helping with OCD, helping with depression, helping with anxiety, helping with ADHD. Um, so I guess my big takeaway there would be to not neglect the ADHD, because I think many clinicians fail to appreciate how profoundly ADHD can interact with and exacerbate all of these other symptoms. And yes, it can be difficult and confusing. So James Alexander asks, other than eye contact or facial expressions, how has the core autism symptom of persistent deficits in social communication and social interaction shown up in autistic people you've met? So other than physical manifestations of it. I mean, one is that there's an overlap between some of the other core autism spectrum issues. So I was just talking to a patient who's in a senior center group with someone who she kind of likes, but is also, he's dealing with autism. And she was talking about, or trying to sort out or understand his autism. And he talked about going to some other group and boasting that he had met 41 people and had made 41 new friends. And she thought it was so odd that he was focusing on the number, and she would never approach it that way. And we discussed that that's sort of consistent with that they're focusing on sort of a superficial aspect rather than on, so someone else might be talking about, oh, I met this who had spent 6 years in the Peace Corps and then started their own business and did this, or I met these people who had done X, Y. They would be focusing on the human aspect or the connected aspect of the people they connected with rather than the number of the narrow. So again, that having hobbies that are, and the term is often used as superficial or focused on the details rather than the content or essence, that leads into social communication. Um, so other aspects of social communication and social interaction is the tendency to focus on s- attributes, superficial aspects of a topic rather than deeper core human relational aspects of it. Or it's describing events where one would expect more social connection or expression of emotions and feelings with more detachment or not apparent emotional registration. So it's, I can follow up if I didn't answer that well enough. So um, you're welcome, Cesar, and you're welcome, Jack. Hopefully those answered part of your questions and transcriptions following up. Um, that an angle I didn't highlight in my answer recently was that mycotoxins are associated with general inflammation, and there is, again, a general association between higher rates of inflammation and ADHD. My, again, whether this, how much is causative is still hard to sort out because it's possible that ADHD makes you more prone to being in situations that contribute to inflammation. It might not only be that, or it might not even be at all that inflammation contributes to ADHD. Again, the association is there, but sorting out cause and effect is tricky with many of these things. James Alexander asks, has finding the right ADHD medication been enough for most of your patients with previously untreated ADHD who also have trouble sleeping, are consistently getting a good night's sleep? If not, what have they had the most success with? I'd say there's one subset of people who being on the right stimulant, again, helps them be active, alert, focused, more tired during the day, probably more tired at the end of the day, helps regularize their circadian rhythms. But I find that a number of people who clearly are benefiting from their ADHD medication do need very specifically, and I'd say of all the lifestyle, all the non-medication, all the other aspects, sleep, I think, is the number one to specifically focus on. And it's usually some variation of cognitive behavioral therapy for insomnia. It's focusing on getting a regular cycle and adhering to it and shutting off distractions late at night and reminding yourself that staying up late, even if your brain is more productive, is going to hinder your productivity and efficiency the next day. And every day you live, except maybe the very last one, you will have a nighttime or evening period. So I'd say very often, aside from medication, getting sleep well regulated needs just special attention to sleep through, again, CBT approaches. So I'm not sure if that answered the question. So top tier billionaire um, says they do drink a lot of caffeine and asks, what about male testosterone levels in ADHD? Any connection? I was diagnosed with hypogonadism, so on a protocol at the moment. So I do have a video on testosterone and ADHD. There's not an extensive literature in terms of treatment. There's a lot of literature research looking at the connection between testosterone during pregnancy and in utero. Um, so, I mean, boys are still more prone to ADHD than girls, even though some of that is a social factor and we've ignored ADHD in women, but there does seem to be still a real sex bias. There seems to be greater likelihood of ADHD in women who got higher doses of testosterone during their gestation, whether it's from having a twin who is a male or others, um, and using finger length as a metric for testosterone exposure in utero. So again, I do have a video, and there are a handful of case studies in which individuals with full, robust clinical ADHD were treated with testosterone, and the test and had I won't say complete, but very substantial resolution of ADHD symptoms. And some of these individuals, every bit as robust or more than they had gotten from stimulant medication. On the other hand, I have a fair number of people who've been on testosterone because for other health reasons, or have been on testosterone blocking drugs because they got prostate cancer. And I'd say globally, I haven't seen a huge impact on testosterone. Just doesn't seem to be generally improving executive functions overall. Um, so it's reasonable to hope and it's reasonable to look for some improvement if you're taking exogenous testosterone, but that's what I can say there. Jack says, I've tried Comparing caffeine from different sources, I think the same amount of caffeine in black tea is more effective than the caffeine in coffee. So, and I talk about this, I think, in my. So, one thing to be aware of is that even the big Starbucks, giant Starbucks, has excessive quality control for how long they roast the beans and where they come from and the color and the aromaticity. And apparently, they don't even seem to be controlling for caffeine content. So, this is a study that's, I think, a decade old now. It was a University of Florida group bought the exact same drink every day for more than 3 weeks and at a Starbucks. And the caffeine content of the highest day was 3 times higher, exact same drink, than the lowest day. So, part of it is you may think you're taking the same drink, but you may get dramatically different amounts of caffeine. But separate from how much is really in your drink is what else is in it with them. And there's certainly, so theanine is one component of tea, and I have a video on theanine, and there's evidence that theanine in combination with caffeine can enhance some of the executive function benefits that caffeine itself has been shown to improve. So, yes, how you're getting your caffeine or what other um, probably biologically active ingredients in what you're drinking can have an effect. Um, Mr. AKA is wondering if Xyrem, Xywav could help ADHD. Um, so Xyrem is sodium oxybate. Usually, it's a medication used to treat narcolepsy. It's also been implicated in some of the date rape cases. I'd say anything that helps with sleep may help some people. I don't know of specific studies or research with ADHD. They may be there. I'm just not aware. And James is asking top tier billionaire if his TRT protocol is doing any sort of testosterone replacement treatment is doing anything for ADHD. I'm not seeing an answer as I'm scanning quickly, but I'm not scanning very quickly. So, um, sorry, it's not letting me scan through. Uh, don't know what's happening. So I'm chopping off a. Sorry about this. Okay, there we go. So transcription, and I have about minutes and a lot of questions, so I'll try to go through really quickly. Says his psych suggested taking a little dextroamphetamine before sleep, like a half tablet, really good for shutting the brain chatter off. So that's something I've talked about. You need to be careful with it because there are many people, even with ADHD, where even a low dose of stimulant at bedtime can rouse them up and make it harder to fall asleep. But certainly, some people, the right dose is helpful for shutting off thought and falling asleep. Nate Smith, is there potential combined benefit of a low dose of selegiline that is selective at MAOB with 400 to 450 milligrams of bupropion for someone who found low, moderate doses of Adderall effective, or is that too risky? Um, Again, I'm not supposed to be making specific recommendations. I'd say there are risks of serotonin syndrome and other issues here. I would say if someone is tolerating 400 to 450 bupropion without problem, then and if they don't have a history of other drug problems or interactions, starting very low and carefully with selegiline may be potentially helpful. But I would be very cautious about it. So, Max, thanks for providing the link on antipsychotics and ADHD. Yeah. So what's unclear again, the MAO with the most evidence for being helpful for an ADHD is selegiline, and it is metabolized into amphetamine. I mean, it's metabolized at all doses, whether it's a sizable, and it's a major metabolite of it. Um, Whether it's because of the MAO action or whether it's because it's breaking down into L-amphetamine, nobody has sorted out clearly. But my thought would be it's usually safer to start with one drug at a time than combining them. So, and Max, thanks for the link in ADHD. Hello, Sniper Channel again. Haven't seen you for a while. What do you think of desmethylclomipramine as a non-stimulant medication? I can't. I'm not familiar. I haven't used it. Is what I can say, and I don't know of. I haven't read the studies about it, so I don't have anything to say there. Transcription says T has a depressing amino acid, plus there's little trimethylxanthine, like such as caffeine in tea. It's predominantly theophylline, um, similar to theobromine. Again, though, different black tea, green tea, different tea varieties. Um, Top tier billionaire felt that the testosterone had some effect on their ADHD, but also seemed to affect anxiety. Max says provide the autism and ADHD link. So Jack asks, how would I distinguish someone who has autism and someone very individualistic that doesn't have autism? So again, my autism video, I would say I have a fairly high threshold for diagnosing autism. So I'll back up. One is I would say fundamentally, when we're using labels, you have the right to use whatever label makes sense to you, even if clinically I may disagree with it. But if you think it's useful or helpful, that's, I'd say, your prerogative. Um, I may explain why I don't think it fits you, um, but I think fundamentally we get to choose our own labels, whether others agree or don't. How would I distinguish someone who's just quirky or individualistic? Again, to me, the definition of autism requires social deficits. So you can be, and the studies or the testing is that people on the autism spectrum don't really comprehend or get reasons for social rules, like why should we have eye contact? Why is it nice to say this? Why do you chew with your mouth closed? It's not that they just aren't doing it or not, they don't understand why that would be good or useful. So there's a deficit in social comprehension. Again, there tend to be stereotypical repetitive movements, and there tend to be idiosyncratic, narrowly focused on, I'd say, the superficial rather than the essence in terms of hobbies. So again, if you're a patient who is so, memorizing radio or railroad timetables or subway timetables is a sort of classic autism spectrum thing. And particularly many of these people who are doing that have no functional awareness of, where these stations are, how the system's laid out. It's sort of arcane knowledge without attention to the essence of the topic they're interested in, rather than someone who's just intensely interested in something but exploring it at multiple different levels. Um, Sorry, I'm scanning. So Jack sees a connection between avoidant personality disorder, schizoid personality disorder, and autism all on the same spectrum, and whether could these personality disorders be seen as a precursor of autism. And usually we don't define or diagnose personality disorders until late adolescence or early young adulthood, whereas autism is classically a disorder diagnosed and identified when we're young. So rather than those being precursors to autism, the sequence there seems to be backwards. So there may be associations or connections, but seeing as avoidant personality disorder as a cause for autism, I would think if someone didn't have autistic symptoms when they're younger, then maybe it really is just avoidant personality disorder. So Mike Poulos, or combo meds show results when someone is taking Ritalin for ADHD, but also dealing with mood disorder, emotional regulation, has tried Wellbutrin and Trintellix with no effect. So Russell, Barkley, and others, I mean, amphetamine-based products, when they're helping with the executive intellectual functions for ADHD, tend to help with the emotional regulation as well. I mean, dosing is important. So too little may not help, and too much, even in someone with ADHD, can make them more irritable and or aggressive. But very clearly, there's a number of studies suggesting amphetamine products can help with the emotional regulation. Um, so Jack says the number one top fan of this chat room should win a book signed by Dr. Kruse. Thanks. I don't know how I would rate or who would rate the number one fan. And so far, I only have one book out, one in production. But Max included the link to the testosterone video and ADHD video. Um, so James Alexander is asking, is there any ADHD monotherapy that stands out in its effectiveness for emotional dysregulation other than guanfacine? And I know Dodson William, might have the wrong name, who has popularized the idea of dysphoria, um, rejection sensitive dysphoria as classic for ADHD, strongly endorses monoamine oxidase inhibitors as helpful for emotional dysregulation. I am not aware of any research supporting that. It could be true, it could be a clinical impression, and I think lots of clinical impressions are shaped by expectations and confirmation bias. So I would take it with a grain of salt, whether it's particularly helpful. So Max also found the links thanks to Caffeine and ADHD video and the L-theanine video. Um, and thank you. You're welcome. You're welcome. Thanks for joining. Spread the word to others who might benefit from some of the information here. It's 11 my or West Coast time, 8 my time, but I'll try to answer the next two questions and then wrap things up. So, local poll roll. What are my thoughts on one a day extended release dose of stimulant medications such as Vyvanse versus splitting it as multiple small doses throughout the day? Do they have different effects? Again, with stimulants, part of what we know is that it's not just how much is at the receptor at a time, it's how quickly that's change concentration is changing. Um, I'd say the biggest reason clinically I've seen people split Vyvanse up is more to extend the lifetime of it. So rather than taking 40 milligrams once in the morning, they might take 20 first thing when they wake up and 24 hours later. Um, and in general, the pharmacodynamic kinetics, y- y- yeah, you're not, I'd say, particularly with the Vyvanse, it's sort of being uniformly delivered as quickly as the red blood cells can break off that lysine. So I don't see people having surges during the day or um, other effects like that. But I've certainly seen other people break up stimulant extended release dosages, particularly to counter siesta effect. My thought is that can sometimes be helpful, but more respecting your biological rhythms is important. So James Alexander asks, for my patients who were able to tolerate atomoxetine, how long was it before the side effects diminished enough for them so they feel they could evaluate its impact on their ADHD at an effective dose? So I've had so few patients on Strattera that I would, again, the biggest factor is that it took many, many weeks to get to an effective dose. I don't think I'm really answering the question, but there. So, and thanks, Max, for reminding people that I'll be one of them, several speakers on Medium Day, which is Medium's big writing platform, um, a week from Friday, 11 o'clock Pacific time. So, so Richard Nixon, I do have a video on magnesium. I think it might be magnesium and zinc or magnesium and something other. It might not just be straight magnesium, but I think if you just Google magnesium ADHD in my name, it will come up, or maybe in the next second, Max may find the link. But yes, there's a little evidence that it helps. I've seen clinically several people felt it helped substantially. So it's certainly for many people a reasonable thing to try. So stay healthy, stay happy. Thanks for all the great questions and positive feedback. And thanks, Max, for so quickly bringing that up. He's efficient and wonderful. Max is not a bot. He's a real person. I won't say any. I've interacted with him in video in ways that he did not appear either autistic or like a bot. I think he's a real person, and he's been incredibly helpful for this channel for the last year. So, and he's quick. Yes. So that's all. Have a great week and see you back next week.